how many of you have laboratory testing, even if it's just lactate, as I discussed Stanford was planning on implementing as part of the sepsis protocol at your hospital? So please go ahead and vote, and we'll see what the results are. And the results are very encouraging. So a large majority of patients do have laboratory testing as part of the sepsis protocol at their hospital, and I think that that's great. I think it's very important, and I want to use my last slide to sort of hammer that point home. This is actually the mouse study. This is a research study that was published this year using mice, and it's a very well-known model for sepsis. It sounds terrible, and probably is terrible, unfortunately, but what they do is they ligate the cecum, and they make multiple puncture wounds in the cecum, and that has a high rate of sepsis development in the mice. Now, all the mice develop sepsis that have this done to them, but only some develop severe sepsis. What this study looked at was the treating of mice with corticosteroids. That's a controversial topic in the treatment of human patients with sepsis. Remember that we think that this systemic immune response syndrome is an exaggerated immune response, and actually the patients do poorly, probably not because of the infection, but because of the overreaction to the infection. And so the use of corticosteroids is a controversial topic, whether or not that will be helpful or harmful. In this particular study, when they just basically randomly chose mice to be treated or not treated, there was really no difference in the survival. But when they used interleukin-6 levels to try to predict the mice that were at high risk of developing severe sepsis as opposed to at low risk, you can see that the use of corticosteroids had a major effect on the mortality. So I think that these biomarkers that we use in the laboratory to identify people who either have or are at risk of severe sepsis will be important not just for the early identification, but eventually they probably will allow the physicians to target therapy to those people who really need it and where it can be most effective. So here's my conclusions. I think hospitals should consider adopting recommendations of the Surviving Sepsis campaign. And I'm very happy to see from our poll question that a lot of laboratorians are involved and that laboratory testing is being used in conjunction with these bundles from the Surviving Sepsis campaign. I think procalcitonin is an effective way to help identify these patients, although probably we'll eventually want to look at a multi-marker approach. And again, targeting intensive therapy to those patients who are identified as being an increased risk is probably the way to go to really make a significant dent in the mortality associated with severe sepsis. So with those concluding remarks, I think I'd like to open it up for questions.
And Dr. Faix, while we're waiting maybe for the first question, I had a couple I'd like to ask. First of all, is there anything known about why some patients with infection develop sepsis and others don't?
No. In that research study that I just showed, for instance, all the mice were treated the same way in terms of the ligation of their cecum, and they all developed sepsis, but only some developed severe sepsis. We don't really know. And the same thing is true in human patients. We don't really know what's really behind that. There probably is some sort of genetic predisposition, similar to allergy, for instance. Some people who are exposed to innocuous pollen just shrug it off, and other people have actually a very violent immune response. And also there's some increased risk of developing severe sepsis with aging, which seems counterintuitive to me because as you get older, your immune system isn't as robust, but that's also been identified as a potential risk factor.
What about protein C? Is it ever used as a marker of sepsis?
Protein C has been used as a marker of sepsis, although not as extensively as some of the inflammatory markers. Of course, it would be low in sepsis, and that might be problematic. You'd basically be looking at protein C levels that are lower than they should be. It has definitely been used to monitor treatment with that activated protein C drug that I mentioned. When patients are treated with that, their protein C levels recover. And it's been used in that context. But I don't think it's been extensively used as a marker of risk of developing severe sepsis, but it certainly could be.
Thank you. What questions do we have from the audience?
I really enjoyed the presentation. I have a question regarding number of procalcitonin tests and the sequence and how many hours after initiation of sepsis bundle. And if possible, rather than reinventing the wheel, is it possible to share the protocol that you have at your institution?
Sure. First, to answer your question about the sequence of testing, I don't think that's been really worked out well. I think we need to do some work there to determine how frequently after initial testing we should repeat the testing. I think that there's evidence that if the initial test is low, below the level that you would even be suspicious, that doesn't mean that they're out of the woods. And I think that you'd obviously want to retest if something happened, if their heart rate increased or if some clinical thing changed. But I think we also probably, as laboratorians, we probably need to develop some sort of protocol where we make a recommendation of frequency of testing over the first 24 hours. That's something that I think we need to work on. And I'm happy to share the experience of the Stanford nursing department in terms of what they're doing, the details about what specific things they're monitoring. I'm happy to share that with anyone who's interested. Just have to email me.
Thank you. I was wondering whether, like, for ruling out myocardial infarction, whether you have a sequence of procalcitonin testing on...
Yeah, I think, are you asking, like, would there be a sort of a recommendation for frequency of testing similar to the way we recommend monitoring troponin in patients who are suspected to be at risk of acute coronary syndrome? I think that's what we need to do.
Okay, thank you very much. And I was definitely interested to get your email.
Okay. I think people can, if you just Google me, you'll probably find me at the Stanford website.
Okay. Thank you very much.
Sure.
Yes, Dr. Faix. Our ED draws many blood cultures due to protocol that they have put together on certain disease states, such as suspected pneumonia, urosepsis, etc. How does PCT integrate with the drawing of blood cultures?
That's a great question. I think that anyone who has a blood culture drawn probably needs a PCT drawn because they're asking this basically the same question. We actually did a study here at Stanford, which we haven't published yet, but we looked at patients who were admitted to the intensive care unit and did have blood cultures drawn, and the PCT was able to predict who was going to have a positive blood culture, and it also could potentially be a helpful negative sign. In other words, if a blood culture is positive with something like staph epi and the PCT is really low, it's sort of a good confirmation that it's a contaminant. So I think that's another area where we need to work together to kind of, both from the point of view of the blood cultures in microbiology and the PCT in the core lab or the chemistry lab, they can be mutually helpful, both in identifying people who do have sepsis as well as confirming that a positive blood culture with a contaminant probably is a contaminant.
Okay. Thank you very much.
Maybe while we're waiting, I'll ask another question. How should we go about validating a commercial assay for procalcitonin?
That's a really good question, and I think for most of the things that we need to do to validate commercial assays, it shouldn't be very difficult, accuracy, linearity, precision. But one area where we may need some assistance is in the reference range. Probably almost anyone who implements procalcitonin will want to use the manufacturer's recommended cutoffs, but you'll need to sort of validate those in some way. I think the example I said earlier about looking at patients who are having blood cultures drawn and are having positive blood cultures is a great way to get samples from people who are at risk and do or don't have bacterial infection. And we did that. And another thing that we did was we basically looked at healthy outpatients to sort of verify the really low risk range. And then I guess the other thing I should just say is that if you're at a pediatric hospital, you need to be very careful about validating the reference ranges in young infants. The procalcitonin levels are higher during the first couple days of birth, and if that's a population where you're using the assay, you need to work with your neonatologist to make sure that you have the appropriate cutoff levels, because the procalcitonin is going to be slightly higher in neonates.
Are there any other questions?
Yes. What scenarios would we expect a false positive procalcitonin? And I also have an additional question.
Sure.
How do you feel about the monitoring of antibiotic therapy, using procalcitonin to monitor that?
Okay. Well, to answer the first question, I think that's a great question. It definitely is not specific for bacterial infection. It's not specific for sepsis. It will be elevated in patients who have severe trauma and probably very severe systemic illness. It can actually be elevated. I don't think it will be elevated as high as it is in severe sepsis, but it definitely can be in the range where you would basically be concerned about the patient. I don't think that's necessarily a drawback in the sense that a lot of what we're focusing on, at least initially, is just attempting to use it to identify patients. And even if there are some false positives, that's okay, because all the patients in the medical or surgical area will just get more close attention. But I think if you're planning to use it as a rule-in, you will have some problems, because it definitely will be elevated in non-infectious severe trauma. And then the other question has to do with a lot of studies that have been done both in Europe and the United States in using procalcitonin levels falling in patients who are known to have bacterial infection and are treated with antibiotics. Basically, when the infection is completely resolved, procalcitonin levels do rapidly fall. And there's a lot of evidence that that can be a helpful tool to help the physician decide that it's okay to terminate the antibiotic therapy and not treat unnecessarily for longer periods of time. But I have no experience with that, and I think that at the moment that's probably still off-label use and needs to be really investigated by the laboratory and the physicians that are considering using it in that way.
Thank you.
I was wondering, in terms of the multi-marker approach, do you utilize that now? And if you do or are considering utilizing that, which markers would you choose together, or do you do it on an individual patient-by-patient basis?
Actually, at the moment, we implemented procalcitonin and basically just said if you want it, order it. We have a lot of interest from the neonatologists who basically use C-reactive protein as a negative predictor that it's okay to discharge the infant from the neonatal intensive care unit. And they're interested in how procalcitonin can be used, probably in conjunction with CRP in that setting. But in the Surviving Sepsis campaign thing that we're going to start, we are going to still do lactate as they originally planned, but we're going to do lactate plus procalcitonin and look at retrospectively see whether or not the procalcitonin was the addition of procalcitonin was more helpful.
Yeah, I'd be really interested in seeing that data because we currently do lactates here at point of care on the iStat, so I'd be very interested in that.
And the other thing that we're thinking about doing is the CD64, because all these patients have specimens submitted for white cell count, of course, and there is a company that does allow you to do the CD64 in the same instrument that you're doing the white cell count, and we have that instrument, and we're planning to look at that sometime early in 2010.
Okay. Thank you very much.
Sure.
The other question is regarding false negative. One mentioned about false positive. How about the false negative results with the procalcitonin? Can you review those?
Yeah, I think that's related to the question about sequential testing. I think there certainly will be false negatives, especially as we try to identify these patients earlier and earlier. We'll be doing procalcitonin tests in patients who are just mildly a suspect of being in early sepsis, and we'll definitely have some false negatives. And I think that the way to deal with that is to develop the protocols we talked about earlier, where we don't just rely on the initial result, but we test sequentially over a short period of time just to make sure that they're not actually developing early sepsis. I can't give you a number of false negative rate. It's probably very low in the published studies because most of the published studies have had a very high prevalence of sepsis, and their patients who had sepsis really had sepsis. But as we look at trying to identify the patients much earlier, I'm sure that the rate of false negatives will increase.
So there was mention that virulence group streptococci, including endocarditis syndromes, typically do not elevate the procalcitonin.
Yeah, I'm not familiar with that report, but I'm not surprised that there are going to be some bacterial infections that for some reason do not. I don't think we really understand why normal tissue cells would make this kind of weird and wacky molecule. It doesn't have any specific function that we know of. It's probably some sort of primitive innate immune response that maybe had some function at some time, or maybe it does have some function. But it's likely that there are some bacterial organisms that don't provoke its synthesis.
Thank you. If there are no other questions, then I think that will conclude today's webinar. I want to thank Dr. Faix for his excellent presentation today. With that, we appreciate your attention and participation. Thanks again, Dr. Faix.
Thank you.